Thank you, Lenny. Thank you very much for inviting me. I think all of us have appreciated what a great conference you've put together, and thank you for doing that. Let's see. That may be the only slide you haven't seen. Okay, as I've listened to this, a number of our adult colleagues have presented. Willis presented a number of data. I was happy to see some of his data was no different than what I got off from the NMDP. But I'm going to talk to you a little bit. We divided this up. I'm going to talk to you about how we got here and where our current results are, and I think we've seen most of those summarized. I think Yossi's going to talk about differences in donors and what you should and shouldn't think about and what myths we need to bust. And Steve's going to talk to you about where we think we're going to be going from this. Okay. So I have no financial or other disclosures. If I mention any drug uses, they will probably not be FDA approved for children, but that's not the purpose of my talk. And this is the only slide, I think, with any animation. So the general principle throughout this has always been try and beat leukemia before it's unbeatable. We've tried to figure that out for at least the 3 decades I've been involved, and a number of you have been involved in this even longer. In the beginning, allogeneic transplant, as it is today, although now today we hear about it in the older adults, it is a competing risk for survival. And so in the early days, the only people we would ever consider were people who were blatantly, obviously in trouble. They had to earn their transplant. They had to either not go into remission or they had to relapse. And in the early days, there were no cures for relapse. And we accepted an ungodly high amount of treatment-related mortality because that's how we got the field started. As we improved TRM, and we've continued to work on that for the last 30 years, we then tried to predict who would be the failures based upon what we were beginning to understand as individual patient and or ALL biology risk factors. And those have been well summarized by people much smarter than I am. But at least in peds, and I'm going to stick much more to peds because that's what I know best, and I think we've had the adult transplant summarized better than I can. But Philadelphia chromosome positive, infantile MLL, high hypodiploidy, and there's always been a question since I started in this as to whether T cells did better, did poorer, and they went into vogue and out of vogue, but I think they are a different disease and have different risks. And in the adults, and I will show you one slide from the NMDP from 2013, we've heard from everybody. Survival is poorer with chemotherapy. I think there have been great strides, and we've learned from this meeting what those strides have done and that they've happily done a fair amount, not as much as they need to in the population that we're specifically discussing. But early on it became, do they have a matched sibling? Do they have comorbidities? Should we move them right on to transplant? And that was sort of the state of where we were at. And so we gathered data and we tried to become evidence-based. As you know, most of transplant for the first decade or two, and some would say all today, is very empiric. But we used data. And some of those data drove our ALL in what we did with Phi positives because, look, with chemotherapy alone, you had a dismal outcome. With transplant, you had a better outcome. Look at the year. Okay. So, but this was evidence-based, and this led to what we did for a long time until we had a much better drug. We learned from our European colleagues, as was just alluded to, that if they analyzed their data correctly, sort of taking out some of the biases, the people who relapse during the time period they're waiting for a transplant or while other people are going to transplant, there really was no significant difference for bone marrow transplant in first complete remission in what was called high-risk ALL during this era. And while each group differed a little bit, high-risk ALL still fell into pretty much the same pot. And the answer from this study and from other studies was you probably shouldn't do this. Our same Italian colleagues were among the group that helped show us all that if you did have a relapse and you could be put back into CR2, there was an advantage to transplant. And hidden in here is another, that 4-letter word, auto. At least here, an auto transplant wasn't terribly helpful. I'm not going to take you through every old slide that showed you we should be transplanting ALL and CR2, but this was the second large cooperative study. Those 2 studies were used by the evidence-based recommendations that came out in 2005. And this is work from John Barrett when he went back and looked at all the UK studies, again, from an era in the mid-'80s to the early '90s. And if you relapsed, whether it was early or late, there was an advantage to going to transplant. We know some of that's disappeared with time. And as we slice the pie differently with MRD, I think it'll disappear even more. We learned a little bit, although I went back and looked at these studies, what's the best way to do it? We still don't know the best way to do it. But from the early studies, there was a very nice French study that was older and I didn't include it. Nancy Bunnan went back and redid it through the Pediatric Bone Marrow Transplant Consortium, and she showed that TBI, whether for a related or unrelated donor, was superior to a busulfan-based regimen, whether you had a related or unrelated donor. I went back and looked. This was oral busulfan. This was not what we would call IV-targeted dosing. So you can find flaws for that study. Similarly, Stella went back through the CIBMTR and got very similar data, and that's almost all oral busulfan. So that's a question we think is answered, but maybe not as answered in the modern definitive times, and maybe we could get away from all TBI-based transplant for patients with lymphoid malignancies. So that came together in a seminal paper. This was actually the third evidence-based review conducted by the ASBMT, and this was pediatric focused. I'm not going to list everybody who was in it, but a great number of very good people looked at that. They looked at tons of papers, and they came up with this as sort of the recommendations. And we lived by them for a number of years. Primary induction failure, we still do. High risk, probably not general. Yes, at that time for Philadelphia, probably at that time, and I certainly transplanted a bunch of babies with MLL during that time, and we are still doing the high hypodiploids. There wasn't a clear message in T-cell ALL, but there was some worry about very high risk. And in CR2, we were pretty sure we wanted to transplant at least the early relapsers and the late relapsers, just as it is today. It's a consideration of what are the patient factors, what is the likelihood of they're going to relapse again, and sort of what is the best route for that individualized patient. Hopefully MRD will lead us down there with knowledge as opposed to Gestalt, which is, I think, the way we've done it before. If you're lucky enough to get into a third remission, we would try and transplant you. And if you were refractory, they did not make a clear recommendation, but they were hesitant to say that had any efficacy. Isolated testicular and isolated CNS, there were no clear indications or recommendations in the 05 recommendation. And they said it should be TBI-based. At that time, there were no good studies saying autologous transplant in pediatrics, except for perhaps the Boston one, which they self-admitted was very, very selective, and they had very good results. But they excluded a number of patients that we would think of as the primary patients we transplant. And because of the data at that time, there just weren't enough matched unrelated data to be able to say that that was equivalent to doing a matched sibling or a very well-matched related donor. So the only thing they could for sure endorse was HLA matched sibling. I'm sorry that got time shifted. So that led us to a bunch of data, and now you're going to see the CIBMTR slides that you've seen from a few of our colleagues, and that Willis showed us earlier this morning. I tried to match them up to prove a few points. If you look here at the results for children under the age of 20 from HLA matched SIBs, they are not terribly different. Every one of these slides shows the same ladder. Early does better than intermediate, does better than advanced. And as you look at the numbers, they are off a little bit. And as you notice, the NMDP has not analyzed their data and presented it to the public since 2011, and that's just a matter of having people mature far enough to have it be meaningful data. But we are approaching very similar numbers in both groups, and I think most of us to this day would now say that that tells us we probably can use one when you don't have the other. This one's never a fair slide. This is the pediatricians versus the adults, and it's not the doctors, it's the patients and the diseases we treat. We all work very hard at this. But we are fortunate enough to get a little more resilient population, probably with a little bit better responsive leukemia, and I think we've now seen some of the biology behind that, that consistently it's 15 to 20 percentage points higher. As we move up, the adults move up. It's just been that way, at least in the 30 years I've been involved. If you look now at the year of transplantation, I like this one because, and I took it out here, but basically the bottom message is we can learn. We can improve over time, and that supportive care, it is certainly when the NMDP went to much better allele level matching. But you can see, now it looks like we've flattened out in pediatrics a little bit over the last 10 years where our adult colleagues are still making progress upward. I hope that doesn't stay flat, and I hope that isn't as high as it gets. But that's where we're at currently today. When you get to the adult data, and I'm not going to dwell on this because I think, as I say, people have shown you these slides, not side by side, but one after the other. I thought there was one interesting thing in here, and it probably isn't real. The survival in the intermediate group looks a little bit better over there, and I think this is probably because if you have a matched sibling, you're a little more generous as who you take to transplant, as opposed to some great graft versus leukemia effect that is coming in here and saving the day and getting you, a few percentage points higher. But we'll have to watch those curves over time and see if they really do stay a little bit higher. So for this, it was just looking again, and this is the direct comparison of the children and the adults. And again, you see the same splay, both of the curves a little bit lower than the matched siblings. This is one slide I haven't seen. So again, another CIBMTR slide, and they credit a lot of this to the fact that we've done better, and this is just a much more recent snapshot, again, of analyzed data. This could be updated because this is day 100 data. But it's showing you the remarkable decrease in transplant-related mortality in early disease, good, but in intermediate disease, and there is even some decrease in the advanced diseases. This is paralleled in adults. It's not quite the same, but we're dealing with a wider age range, and certainly people my age, which would be included no longer in the AYAs by anybody's imagination, but certainly in the adult group, and we all have comorbidities. So we learned a few things. We learned during that time, as we've heard a number of times, and I remember Rick O'Reilly saying, the ALLs we're swinging at today are not the ALLs we treated in the 1980s. These are children who've been through the best our incredibly bright colleagues can throw at them. And the kids who relapse now have a much greater treatment burden, and they probably have a much more refractory disease. And I think that's the way the transplanter comforts himself when his curves don't get better over the time, is you're doing just as well with a worse disease, but we're still not doing well enough. So some of the data that was gathered, and this is the Kirk Schultz paper, I think this is the 4th time we've seen this, but this basically said, don't do transplant. We can do just as well. Matter of fact, we can do better with TKI inhibitors and chemotherapy. And this lesson is well learned everywhere. What may not be as familiar to our adult colleagues is our French colleagues during their Interfont study basically confirmed that there is a really nasty group of babies who get MLL-positive leukemia and don't do well. And they are definitely benefited by transplant. But these are children who have a bunch of very specific risk factors, and they're under 3 months of age, they have very high white counts. And if you have the children that a number of us transplanted that were 6 to 12 months of age, therefore still a baby, they showed that transplant really didn't give them a benefit. So we don't do that anymore. And if new drugs come into being, drugs that at least one of my partners is testing back in Denver, that gives us a small molecule inhibitor of MLL, maybe we won't do transplants at all in first remission. We certainly don't do many because there aren't that many of these babies. We learned here from the BFM group that what they were considering a very high-risk T-cell ALL was benefited by stem cell transplant. And this group showed there was no difference in their cohort of patients between choosing a matched unrelated donor and a matched sibling donor. So that was, again, it's later work, and it shows what some of the more modern supportive care and HLA can get us. In this very simple slide by Mary Ipan, she teaches us a few lessons. First, if you are a late relapser, and that would be D and E, it doesn't matter. You're going to get a reasonable outcome. This is without any MRD data. This was all based upon the biology of the patient's leukemia came back, and you were lucky enough to be able to control it. I thought there were a couple of interesting things. If you relapse late and you got a non-TBI-based transplant, you had pretty inferior outcome. That was recapitulated, so if you relapse early, and we all know this, chemotherapy will get you some survivors. Transplant gets you a better, not a hugely better, but a better survival group. What I don't think any of us expected was a non-TBI-based transplant in this very high-risk group had dismal results. And again, this is all comers. A great percentage of these would be oral busulfan, many of them without detailed therapeutic drug monitoring, and perhaps that would allow us to do better, but that's never really been definitively tested. In a much simpler slide by Mary, she basically looked at the outcome of isolated CNS relapse and said, There is no reason we should be transplanting the majority of these children. I think, unfortunately, Steve's gone. Maybe Peter could speak to this later. But I know that there's a group now in COG that they're looking at of infants who have early CNS relapse, and they may be a very different risk group. And we are going to analyze that and consider whether they should go to transplant or have some sort of augmented therapy. Perhaps those would be eventually children who would become available to CAR therapy, because as Stephen showed us, they get into the CNS. Okay. This was the one slide I found, or actually didn't find, Steve Newdorf gave to me about results in adolescents versus younger children. And this was an Italian study. I don't have all the details, but this one at least showed equivalency in this group of patients. Okay. And so all of these data are what led up to the most recent criteria, and again, these were data taken up till about 2010, just a little beyond, and then analyzed and put together for the 2012 evidence-based review update. And they said a number of the same things. We do it in primary induction. We shouldn't be doing it in CR1. You shouldn't do it in pH-positive ALL. You should only do the MLL children if they have other risk factors. We're still stuck doing high hypodiploidy. I know that there are strategies that at least Steve Hunger's discussed that he hopes will make it unnecessary for them to see us unless they have a much bigger biological event, such as persistent MRD or blatant relapse. We're still doing early relapse. It was recommended at that time. Late relapse, really, an individualized choice was recommended. All T-cell ALL in second remission. CR3 was a no-brainer. They did take a couple of things. So there was this line in here, because of course by this time there were now MRD data. It wasn't definitive, but just as they hinted in their first one that we should look at the TKI inhibitors, they made the statement here that persistent MRD probably was an indicator and may actually be a guide. And I think we've heard enough today, and I'll supply a little bit more data, again in repeated slides, that it is a guide. They did make a few other statements. They basically said you shouldn't do refractory ALL that you have no control over because the disease survival is well under 10%. And that, I think, as we've heard from most people, that is still an adage we follow. Isolated testicular, there really are insufficient data, but there are no compelling data to say that this is the right thing to do. We have very good survival. And again, isolated CNS, not in average pre-B, perhaps if it's early on, and it's still unclear in T cells. The recommendations have changed in terms of allotransplant. They now said an allogeneic hematopoietic stem cell transplant with the best possible HLA match should be pursued. But and they pointed out in a number of studies there was higher morbidity and mortality with increased mismatch, whether it was related or unrelated. This was pre-Johns Hopkins haplo. They were pretty definitive on saying TBI-based, although I did not find any more papers that were referenced in that. That was still using the old data. And there was still a statement that there was no general benefit from doing autotransplant in pediatric ALL. This is the slide I found for adults, and it's not terribly different. What we've heard this morning is MRD is going to really lead the way. But as I think we just heard today, there's still a debate as to whether you go in CR1, because once you get into CR2, if you get there, you don't have much time to get to transplant, and the results aren't terribly encouraging. Primary induction failure has always been an indication, and I think now we're moving into the MRD-based. And so the MRD approaches, as far as I could define them, and I think we've heard them well described today, they're in defined risk groups and at defined primary treatment time points. And if you look at the papers, that's what they say. This may or may not be generalizable. This is true for this induction regimen followed by this. I think the fact that it's a recurring theme in many induction regimens probably tells us it's a biological fact, and at least the principle holds across the board. The exact level, I think we've heard 10 to the minus 4. I think that more studies will hopefully confirm that, and as we have the ability to go much deeper, we may find out that that number was good, but not as good as we can get. They have been used to estimate, and this is what I'll speak a little bit about, transplant outcome by a single time point pre-stem cell MRD assessment. And that doesn't take into account what shape the patient came to you, what he or she got, but a snapshot in time turns out to be very predictive. And then there are data that are just now getting more mature that really monitoring after transplant with the idea if you see recurrent MRD, you try and intervene. What you try and intervene with I don't think is well worked out, but I think we've heard a number of very good ideas in this seminar. So this was the early study out of Tony Oakhill's group, and they went and looked, and I will point out that this was 1998, and this was a PCR-based, and they looked at people who at that time were MRD negative, and I believe the cutoff was 10 to the minus third, or positive, and people who were 10 to the minus 2 or greater didn't do well at all. Okay? People who were less did intermediate, and people who were negative by that assay at that time point did the best of all. And this has been a recurring theme shown to us, and the reason for failure was, as we've seen in other slides, relapse. Yeah. We've seen that, so that was PCR-based. This is, Wen Liang's and Dario Campana's data from the St. Jude's group, where they showed very much the same thing. If you were negative, you had the best survival. If you had low positive, you were intermediate, and high positive correlated with more disease burden, and all these people were in morphologic CRs. So we're able now to look deeper, which is, I think, the message the whole way along. I think again, going back to the BFM group, they've broken it up in the nicest way, just by at least current standards, and shown that it is really a graded phenomenon. Wen Liang got to that point in his paper, but he didn't have all this data. And so I thought it was a little bit better to show us that, if you really can achieve negativity, and I think negativity will evolve as we get better technology and better interpretations, but you can do better. Yeah. This was the University of Minnesota. I mean, this is a universal finding. It's from every country. It's from every group. And in this very busy slide, I think there were a number of things that our BFM colleagues told us. So this is the result of their 2002 study, and they're showing that this was an intervention-based study based on MRD. And so this is proof of principle. They made the results of MRD positive and MRD negative look the same, whether you're looking at leukemia-free survival, overall survival, or relapse, or death. Always important criteria. They then went back and compared this to a historic control, same type of approach, but in this study they monitored. This is the study that defined the levels for them that they wanted to react to, and that was the survival. So they're showing us that if you have positive MRD, you do poorly, and if you intervene, you do better. So, and then the final one was we've heard today, will MRD totally replace risk factors? Well, probably not, because we know that early relapse is a high risk factor versus late, and you can just see this is in the good MRD group, but if they relapsed early or late, their survivals were significantly impacted. And finally, this is another group who had looked at the role of MRD post-transplant, and I think we've again seen a little bit of data there. And so this would be their overall survival, showing you the effect of pre-transplant MRD, but really looking at day 100, and as we saw yesterday, looking even at time points beyond. If you have persistent MRD, you're unfortunately going to be in this group with very high relapse and very poor survival. So that sort of leaves us. I've made this as brief as I could since I saw most of my slides in earlier talks, that allogeneic transplant can be curative for both pediatric and adult ALL. I still think we're looking for the exact cocktail, that risk and biological factors are very helpful in sorting them, and the risks are the usual ones, but that we're going to probably be moving to MRD as one of the major risk adapting strategies. And what MRD we use and what level of MRD still remains to be determined. I think we've heard great data at this meeting saying that we get very similar results with the current MRD systems in place in the US and Europe, and we've heard why they evolve differently. but they're looking at similar, very similar levels. When I sat down and chatted with Steve Hunger, his point was in the labs that are reporting this, the really good labs, when they say it's between 10 to the minus fourth and 10 to the minus third, it's either way. You know, it could be by flow, it could be by, you know, PCR. The results we get from deep sequencing may lead us down a much, much more defined path, or they may lead us down the garden path if we start treating disease that may be below the levels that we understand the biological meaning of. The real question is, what are there pre-transplant strategies that will reduce MRD, and will it matter? Hitting somebody really hard immediately before and getting a better number for one day, is that going to be a biological difference? And the argument we have at our place is, how many more times, and this is, you know, sitting in the leukemia team with Steve Hunger, how many more times do you want me to beat this kid up until he, you know, you'll take him, or he becomes a non-candidate? And we've actually had a few children that we tried very hard to put into a better MRD state, and we achieved a state for which they were no longer transplantable. They would get an invasive fungus or some other terrible complication. So again, it's risk-benefit. The answer is you get survivors even with positive MRD. And maybe we should be looking at post-transplant strategies, but I will leave that to Steve, okay? And on that, I will go back to the T for T cells.